For the next, say, 15 minutes or so, which is, I guess, as long as we have, what I'm trying to do is go through some of the steps of DSEC surgery, go through some of those steps of DMAC surgery after that, and then, if time permits, briefly look at femtosecond anterior lamellar keratoplasty. So to start with DSEC surgery, I just thought we'll go through the steps before we actually look at the videos. DSEC does stand for Descemet stripping automatic endothelial keratoplasty, and if you look at the part of the cornea that we transplant in DSEC, this is the donor part of the cornea. It involves part of the posterior stroma, the Descemet's membrane and endothelium complex, which is part of the donor lenticule. For the recipient cornea, what we do is we strip only the Descemet's membrane and then put in additional tissue. So this is actually a procedure where we add in tissue. The four main steps of DSEC surgery are preparing the donor tissue by different methods, which we'll go through very shortly. Stripping the Descemet's membrane, again very simple, straightforward method. Inserting the donor lenticule inside the eye and then ensuring that you put an air bubble so that this sticks well. So how do you prepare the lenticule or the donor graft? You can prepare it either using a manual method with a pair of dissectors that I'll show you shortly. You can do it in the eye bank or in your operating room using a microkeratome, or some surgeons have used a femtosecond laser to prepare the graft, but this hasn't met with much success. Very simple method to prepare the graft in your operating room is to have an artificial anterior chamber, costs around $65, and have a set of dissectors. These are probably the best that I've used, but you can choose whichever ones you want to buy. All you need to do is to mount the donor graft on top of the artificial anterior chamber, make a pre-cut with a diamond knife or maybe with a guarded knife, 300 to 350 microns, and then use a dissector to go straight across and dissect the entire cornea, just like how you would create a tunnel in SICS. The idea here is to create two planes, an anterior lamellar plane, which is approximately 350 microns thick, a posterior plane which is between 100 and 150 microns thick, which is what you want to transplant into the eye. Once you finish your dissection, you turn this around and you punch it from the endothelial side like how you would punch a routine penetrating keratoplasty graft. The second way of doing this is again using a microkeratome. A microkeratome does have a blade at the bottom, and it works exactly like how you have a microkeratome with LASIK, except that it doesn't have a hinge. So once you take the cap off, you mark the edges and then you place the cap back on, and then you turn the cornea around and punch it again from the endothelial side. So this is how you prepare the donor lenticule. Now I'm going to show you a video of DSEC surgery which is from start to end unedited. And this is a video that doesn't involve the graft preparation. So what I'm going to show you is one complete DSEC surgery. So what you will see here is this is a patient who has Fuchs corneal dystrophy, has had cataract surgery, and you see that the patient has an edematous cornea right now. This is the site of the original incision, and what we are starting to do is we are starting to mark the site of where you want to place your graft on the epithelium of the cornea. Once you have that mark where you want to place your graft, then you can decide where your incisions are going to be. Now you see that here I'm making a paracentesis and I'm starting a little more anteriorly, and the internal entry of the paracentesis is within that ring that I'd marked. I'll come back to that in a little while to tell you why that is important. Then we're using viscoelastic inside the anterior chamber. In this case we're using Helon. You cannot use HPMC because it's difficult to wash away from the endothelium. So once you've used Helon, what I'm using here is a reverse Sinskey hook. You see that it's blunt tipped, going all around approximately 6 millimeters diameter, making an incision from the back of the cornea, trying to incise the Descemet's membrane. What is important here is to have a continuous round, a continuous circle, so you can remove the Descemet's that has been cut by a continuous circle. The Descemet's does not need to be removed in the periphery, and only the central part with the gutte needs to be removed. So once you've cut the Descemet's, it's better to remove it as a whole strip, so you don't leave any tags of the Descemet's membrane residual on the stroma. So once that is done, I typically use a clear corneal incision. You can use a scleral incision if you like, but then that kind of incision should depend on the type of instrumentation that you have for inserting the lenticule. Here I'm making a vertical incision on the cornea, pre-cut, And I'm going to spend some time here using my keratome trying to make sure that my tunnel is a little longer than what you would typically use for cataract surgery. Again, there are two reasons for that. One is I want to go anterior to where the entry of the previous incision is in the cornea. The second reason is, you will see once I put the graft inside the eye, is the fact that you want your graft to overlap the internal entry of your keratome. So once you make your incision, this you see it's a little more anterior than you would normally do. This is a temporal incision, as you can see again. And once you extend it to approximately 5 millimeters, this is a 5 millimeter wide incision done temporally. You can use a smaller incision, but all this will be based on the kind of insertion technique that you have. So here again, I'm using irrigation aspiration to wash out all the helon. This again needs to be meticulous, because whatever helon or viscoelastic you leave behind is going to be present between the donor graft and the host stroma and might cause haze and might prevent the donor graft from adhering well to the stroma. So once you wash out all the viscoelastic, the next step is to take the sheets glide. This is the simplest way of inserting a DSEC lenticule. And for those of you who are starting DSEC, this is probably the procedure you must follow, because this has the potential for the least amount of mistakes. Put the sheet slide into the anterior chamber right across the pupil to the opposite angle. Put a blob of helon on here, and then you'll see that some of the helon goes on to the surface of the cornea also. Now this is the punched graft along with the anterior as well as the posterior caps unseparated. You take it as a whole and you put it on the sheets glide. You don't separate them. Once you're on the sheets glide, then I'm holding the anterior cap, lifting it off with a Sinskey hook in the interface, leaving only the donor graft with the endothelium side down. The endothelium side down is resting on the blob of helon. Then I hold the lip of the tunnel and just slide the graft inside using a bent 26 gauge needle, just like a cystitome. Take out my needle and then take out the sheets glide. Once I do that, then I'm going to spend some time using a saline wash to wash the interface to ensure that any viscoelastic that might have entered in inadvertently is washed out too, and also deepening the anterior chamber so that the graft opens up without any problem. So what I'm trying to do here is I'm trying to wash the interface, deepen the anterior chamber, and also using my cannula as a guard to prevent the lenticule from slipping out of the eye. So once I'm sort of happy with the fact that my lenticule is opened up completely, then I'm going to stop the saline wash and start to inject air. Now the first injection of air bubble, it's preferable to do it from the main incision to ensure that you know where your tip of the cannula is present. Once you have a small air bubble, then you can go in from the side port and supplement the air bubble so you have a much larger bubble. So this you see is the graft, and then you can use pressure on the surface or massage to move it around whichever direction you want. Again, what I'm trying to do here is I'm trying to move it towards the tunnel so that eventually it will overlap the internal ostium of the tunnel. Then I go into the side port. You see the internal ostium of the side port also is covered by the lenticule. So I actually have a valve kind of mechanism where both the internal openings of the side ports and the main incisions are sealed by the lenticule. So once I'm happy with the centration, you'll see that you can supplement the amount of air inside the eye by opening this valve and injecting a little more air. What is also important is here, I'm going in through the side port, going there, detaching the lenticule, injecting air and coming out suddenly. So as soon as it comes out suddenly, it shuts like a trap door and the air doesn't have anywhere to go. So you have a very firm globe that will ensure better adhesion. Once this is done, it's also important to ensure that no part of your graft is present within your tunnel. So I'm going in again through the side port, lifting off the graft off the posterior part of the stroma and then letting it attach again. So to ensure that it is not within the tunnel but behind the tunnel. And then my final injection of air. That's my final injection of air coming out suddenly again. And then trying to massage the surface to ensure that there are no fluid pockets in the interface. So this is about it. This is about the end of DSEC surgery at present. But the only problem is if you leave a complete air bubble inside the eye, you're likely to have a pupillary block the next day. And that's the reason why it's important to go in after 5 minutes, create a shorter side port. This is a shorter side port, and exchange some of the air with saline. What you need to ensure is to have a freely mobile air bubble inside the anterior chamber, and this is what you're going to be seeing the next day. So this is a way in which you can do dissect, like I showed you, a completely unedited video to ensure that you have good graft adherence the next day. So how else would you like to insert the lenticule inside the eye? There are a number of methods by which you can insert the lenticule inside the eye, and I'm going to show you some of those methods. One of the other methods that you can use to insert the graft inside the eye is to just fold the graft into what you would call a taco fold. So here you see that the graft is folded into a taco, or if you would like to call it like a roti, and then pushed inside the anterior chamber using a non-coapting forceps like an Ogawa forceps, left inside the anterior chamber. Then I'm using a 26 gauge needle that is bent upwards to hook the graft and then gently inject air so that the air actually helps to open up the graft, and then you can spend some time centering the graft inside the eye. This is important again because you can use a smaller tunnel to put your graft inside the eye as compared to the previous sheath glide. What is important in this technique is after you separate the posterior lamella from the anterior lamella, what is important is, since there is a potential of graft reversal, it's important to mark the graft with whatever letter of the alphabet suits your fancy, so you can ensure that you identify the correct orientation after you put the graft inside the eye. There also are a number of other techniques for insertion, but I'm not going to go into the details of each of them. I'm going to show you only my current preferred method of insertion, which is the Busen glide. So this is the Busen glide on which you load the graft and then you hold it at the edge of the tunnel that you've made inside the eye, and you've marked the edge. This is the graft that is present. Come out from the other side with the capsulorhexis forceps, hold the graft, and once you hold the graft, you can pull it inside with the endothelium, which is there completely internally, so it doesn't touch any external part or any external instrument. This, I think, probably has the least potential for loss of endothelial cells, and once you, as you can see, the graft is being pulled inside, it opens up quite well. You have an anterior chamber maintainer, making sure there is a deep anterior chamber. So once you have the graft inside the eye, you switch off the anterior chamber maintainer, inject air, and then you're finished with surgery. So that's how you use Busen glide. So I'm going to stop with dissect surgery right now and go very quickly towards showing you one surgery of DMAC to understand the difference between the two techniques. So DMAC is been touted as a replacement for dissect, but then again, DMAC can be done only in situations where you have a relatively clear cornea. If you have a lot of stromal edema, you can't do DMAC surgery. So DMAC surgery involves putting a Desma's roll inside the anterior chamber. You see how this roll is present. The roll tends to curl upwards with the endothelium on the outside. Then you use an air bubble to flatten out the roll. This is an animation to make it look easier. Once the roll is completely flattened inside the anterior chamber over the iris, you allow it to stay for some time, and then you take out the air bubble from on top of the roll. Once you've done that, then you have to go behind the roll and inject another air bubble to allow the Desma's membrane to stick to the cornea. So let's watch the surgery in real time. So this is DMAC surgery where I am loading a glass tube with the Desma's membrane roll, injecting it inside the eye. Once you inject it inside the eye, there is no way of knowing the orientation of the Desma's roll. It can be up or down. So what you can do is you can use a syringe and go inside and tap it to find out what side it's open. What we do is we use an OCT to identify the orientation, and you see that the Desma's roll is oriented the wrong way. It has the endothelium on the top. So what we do is, again, we use fluid jets to reverse the polarity or reverse the orientation of the Desma's roll. It goes to the periphery and then it comes back and then it turns over itself, and once it comes back to the center, this is the orientation that you would like. So at this point of time, again, we do an OCT, and you see this is the orientation that we want. This is the Desma's membrane, and it should be folded such that the endothelium is on the outside and the free ends are facing upwards. So once you do that, then what I'm going to do is I'm going to put a small air bubble in the center, then use the air bubble to open up the folds of the Desma's membrane so that the Desmaze is lying flat on the iris by the time I finish. So I'm using this air bubble to open up these folds, and then once I've done that, then I increase the air inside the anterior chamber to flatten out the Desmaze membrane, then leave it for 5 minutes, take out the air, and finally insert an air bubble behind the Desmaze membrane. So DMEX surgery is a very gratifying surgery, and we've started doing DMEX surgery only for cases where there has been there's relative clarity of the cornea, but in most other cases DSEC probably is the way to go. So I don't think we have time for FALK because I think it's 11:30 already, so we're going to stop right now. So I probably think there are 5 minutes for questions. We can ask questions, or once we come down maybe you can have a short discussion. Thank you.